Thank you, Mr. Chairman, and thank you all for being here today. Rural patients, like my constituents back in West Virginia, are disproportionately left without critical support that they need to recover after major illnesses. But it also is from surgery. This lack of access to essential care not only affects their recovery, but it also increases their risks of complications, leading to longer hospital stays and a diminished quality of life. One way to address this critical gap is to expand telehealth usage in post-acute care settings. I introduced the Hospice Recertification Flexibility Act, which passed out of this committee last year. My bill would allow hospice providers to use telehealth to conduct face-to-face visits required for hospice recertification. Mr. D'Angeli, not only do patients suffer from a lack of proximity to necessary care, but their families and spouses are also deeply affected. For caregivers and loved ones, the inability to regularly visit or assist in the recovery process can lead to emotional, financial, and logistical strain. With these challenges in mind, will you speak about the impact of lack of access to care in rural areas upon your patients' spouses and families, and the challenges that they face visiting their loved ones?
Well, thank you for that question. It is a very real issue for family members. We recognize that treating patients in post-acute care is not just treating that patient, it's treating the entire family. It's making them comfortable and confident to take their family member back home once they finish their episode of care. And so I know we've tried to institute various ways to make it easier for those family members to access the care we provide at Madonna. We provide some family housing. We have the ability for family members to stay in the patient's rooms. They have access to amenities that would support their relocation for brief periods of time, to our vicinity. I think that the part of the bill that Congressman Hearn talked about and that you also co-sponsored is making it helpful and useful for folks to come to an LTAC and for that LTAC to receive payment for them, admitting directly from that critical access hospital. And so that would hopefully help the patients and their families receive the care that they need.
Thank you. Long-term care hospitals are critical for patients who require extended care. The cost to treat the complex medical needs that the LTCH patients require can be significant. The reimbursement system for the LTCHs is structured to help manage these costs, but recent changes to the high-cost outlier threshold have introduced new financial challenges. By raising this threshold, the amount of reimbursement LTCHs can receive for treating particularly costly cases has decreased. This puts additional strain on providers, and it affects the level of care available to patients. I introduced the Patient Access to Long-Term Care Hospitals Act, which will provide adequate reimbursements for LTCHs. My bill also caps the high-cost outlier amount to $50,000. With this in mind, Mr. D'Angeli, what has been the impact of the increase in the high-cost outlier threshold for LTCHs on providers, such as yourself, and the patients you treat?
Well, from a provider and patient perspective, prior to the increase, the significant increase in the high-cost outlier threshold, for instance, when it was $27,000, I know from a financial standpoint, we were able to allow more patients who would enter into the facility who we knew would become high-cost outliers, because that fixed loss amount was such that we could manage that and still make a relatively small margin within our long-term care hospital. And at that time, it was close to 4%. When that doubled, and it went to $58,000 or $57,000, what we saw was that we had to provide more scrutiny, even though we continued to admit those patients who would go into high-cost outlier status, the financial impact of doubling it resulted in our overall LTAC margin falling from that 4% to a -3%. So when you're talking about a significant number of cases, and for us at that time, our high-cost outlier threshold was about 30%. So now we have to limit that in order to just maintain financial solvency, which denies patients access to the care that they need at that point in time.
Thank you for your answer. I have to yield back. I'm out of time.